Okay, so welcome to this next video in the playlist on asthma. In this video, what we're going to talk about is the use of phosphodiesterase inhibitors in the treatment of asthma. Okay, now these are not a first-line treatment for asthma. If you have very mild asthma, where the asthmatic attacks which you suffer from are quite mild, and also you have them very infrequently, okay, so it's intermittent asthma attacks with large intervals between the neighbouring ones, okay, then the treatment that would be given is you would give an inhaler which has either salbutamol or terbutaline in, okay? And these two drugs are the main examples of short-acting beta-2 agonists. And basically, you don't take it prophylactically. Instead, you just use it when you're actually having an asthma attack to relieve the symptoms, okay? So, when you've suffered from an asthmatic attack, you will use the inhaler and it will help to reopen your airways and restore to some extent normal breathing. Okay, as your asthma becomes more severe, i.e. You're getting more severe asthmatic attacks, so the asthmatic attacks themselves are more dangerous, they're obstructing your breathing more, and also you're having them more persistently, the frequency of them also goes up, then you can start taking prophylactic measures, okay? So you'll start being given drugs that will have to be taken on a daily basis, and they aren't aimed at attacking an asthma attack once it's started. They're aimed at stopping an asthma attack ever from happening, i.e. they're a prophylactic measure. Phosphodiesterase inhibitors are used as a prophylactic measure against asthma, and they're taken orally, okay? So they'll be taken orally on a daily basis, and they can help to prevent asthma attacks from occurring. So in order to understand why phosphodiesterase inhibitors are going to be effective at prophylactically treating asthma and reducing the chance that you will have an asthmatic attack, we need to understand the pathology of asthma. So we're going to go over a very basic storyline for what happens in the pathology of asthma, and then see how these phosphodiesterase inhibitors are going to help prevent an asthmatic attack. Okay, so we'll start off with the structure of a normal bronchus, then we'll talk about the pathology of asthma, how it starts with a type 1 hypersensitivity reaction which produces IgE against some allergen, at least in allergic asthma anyway, and how then that propagates to you suffering from allergic asthmatic attacks every time you're re-exposed to the allergen. Okay, so let's start off with the structure of bronchus then. Right. So, when drawing a bronchus, it's always a good idea to start by drawing a tube. Okay, so we're drawing a cross-section of a bronchus. So, I'm going to start by drawing the epithelium of the bronchus. So, these are the epithelial cells that line the airway, basically. Here they are. Right, so the epithelial cells which line the airway are columnar epithelial cells. So, let me draw these here. So they're big, tall, column-like cells, which is why they're called columnar epithelial cells. Okay, and interdispersed amongst these columnar epithelial cells, you'll have a special cell type known as a goblet cell. Okay, now goblet cells are going to secrete mucus onto the surface of the epithelial cells, and this mucus is going to line the lumen of the airway, basically. So let me put some of these goblet cells interdispersed amongst the epithelial cells, so I'll show them by colouring them in green. So these green cells, these represent goblet cells rather than columnar epithelial cells. So most of the cells here are what are known as columnar epithelial cells, okay, and that word columnar literally means like a column, okay, so it means that they're nice and tall epithelial cells. These are very different from these sort of epithelial cells that you have lining the blood vessels, for instance, often known as endothelial cells, but they're a type of epithelial cell, and they're very, very flat. They're like fried eggs is what they're often compared to. Right, so these are nice, tall epithelial cells. And then interdispersed amongst the columnar epithelial cells, you have these goblet cells in green, and these are mucus secreting cells. Okay, so the columnar epithelial cells then have cilia, so they are ciliated. Okay, now cilia are these little finger-like projections from the apical membrane of these epithelial cells that project into the lumen of the bronchus. Okay, so you have little finger-like projections from the apical membrane that project into the lumen of the bronchus. Okay, and these are called cilia. So this is cilia. Right, now what's going to happen is the goblet cells are going to secrete the mucus that they're producing onto the surface of the cilia. So you're going to get this layer of mucus on the surface of the cilia. Okay, like so. Right, and this is going to produce what's known as the mucociliary escalator. Okay, so the goblet cells are going to secrete the mucus onto the surface of the cilia, and what's going to gradually happen is the cilia are going to waft, they're going to gradually move very slowly, and they're going to waft this mucus up. Okay, now which direction do the cilia waft the mucus in? Well, they waft it in the direction where it goes up and out. So it will go from this bronchus into a bigger bronchus, then into a bigger bronchus still, until it finally gets into one of the primary bronchi, either the right bronchus which supplies the right lung, or the left bronchus which supplies the left lung, obviously depending on which lung we are in. Okay, and then it will go into the trachea. Okay, and then it will go up the trachea. The trachea is ciliated as well, through the larynx, then out of the respiratory tract altogether into the laryngopharynx, and then down the esophagus into the stomach. Okay, so this is called the mucociliary escalator. Now, what's the point of this? Well, basically, the idea is that if you inhale some dirt or pathogens, okay, they're going to come down into the respiratory tract, and they're going to get stuck in the mucus, is the idea. And then the mucus will gradually get cleared, basically, by this mucociliary escalator, and it will be moved into higher bronchi, then into the trachea, up through the larynx, out of the respiratory tract into the laryngopharynx, and then down the esophagus to the stomach. And there, obviously, everything will be destroyed. Okay, so this is a way of preventing the airways from firstly getting dirt lodged in them and also getting infected. Right, so the mucociliary escalator is a very important part of the innate immune system. It's one of the ways that you stop the lungs from getting infected. And really, to demonstrate how important the mucociliary escalator is, if you look at people with cystic fibrosis where the mucociliary escalator is dysfunctional, okay, they get very severe infections of the lung, okay, involving Staphylococcus aureus, Haemophilus influenzae, and then finally Pseudomonas aeruginosa species. Okay, so those bacterial infections are very severe and can often lead to the death. Okay, so the mucociliary escalator is very important. Okay, now let's continue on with our discussion of the structure of a bronchus. Okay, so these epithelial cells, they are sitting on a basement membrane. So what's actually holding them in position? Why do they stay in the same position? Well, it's because they are attached to a basement membrane which surrounds the entire structure. So all of these epithelial cells are sitting on a basement membrane. Now the basement membrane is mainly made up of collagen. Okay, there are other proteins in it other than collagen, such as laminins and also fibrillin, but the main component of the basement membrane is collagen. Now, all of the epithelial cells are attached to the basement membrane. They have integrins in their basolateral membrane which attach to laminins which are in the basement membrane. Okay, so all of the epithelial cells are firmly attached to the basement membrane. Right, now underneath the basement membrane you have another layer of connective tissue. Okay, and I'm going to show this in blue. Right, so underneath the basement membrane you then have another layer of connective tissue which I'm going to show here. Okay, and this layer of connective tissue is going to mainly consist of collagen. okay, but it will also consist of other connective tissue such as heparan sulfate, which isn't a protein at all but a polysaccharide, so it's just extracellular matrix basically. Okay, now this layer of connective tissue is known as the lamina propria of the bronchus. Okay, so I'm trying to make it a little bit more substantial, so it's in blue, which it was a bad choice because it doesn't really stick out from the turquoise of the basement membrane, but never mind. Okay, so this is what's known as the lamina propria. Okay, now what's in the lamina propria? Well, there's a lot of connective tissue, but there are also certain cells and also some important blood vessels, which are going to be very important in asthma. So the lamina propria is going to be extremely important in asthma. It's the site where asthma occurs, basically. So let's show some of these things that are in it. So here is a special cell that's within the lamina propria. Now, what is this cell? Well, this cell is what's going to be known as a mast cell, and these are the cells that are going to trigger an asthmatic attack in allergic asthma. Okay, so these are going to be very, very important later. So the mast cells are within this lamina propria. Then also, you have blood vessels within the lamina propria, so I'll draw a blood vessel here. And these are also going to be very important because in an asthmatic attack, you're going to get an acute inflammatory response. And the acute inflammatory response is caused by blood vessels, okay, so small microvasculature blood vessels. So here are these small microvasculature blood vessels. They're in this lamina propria of the bronchus. Okay, right. So, just before we move on to the next layer, let me just give you another piece of terminology. Okay, so there's a word that people love to use, which is mucosa. Okay, now, mucosa is a word which means the combination of all three of these layers that we've discussed so far. So, mucosa means the epithelial cell layer, along with the basement membrane, along with the lamina propria. So all three of these together makes the mucosa. So this is the bronchial mucosa. Okay, so people love that word. And it doesn't just mean the epithelium, okay? It means the epithelium along with the basement membrane that it's sitting on, and then its lamina propria. Okay, right. Now, underneath the lamina propria, there is then a layer of smooth muscle cells, okay? So I'll show these in red here. So these are bronchial smooth muscle cells. Right, so this is the smooth muscle cell layer. And these bronchial smooth muscle cells are going to be arranged in rings, basically. Okay, so let me show this with a picture because this is quite important for understanding what these bronchial smooth muscle cells are going to do. So this is the smooth muscle cell layer. Okay, right. So what you'll do is you'll connect up many bronchial smooth muscle cells together like so. Okay, so you connect them end to end like so. Okay, and you form rings of smooth muscle cells. Okay, and what you can hopefully see is that if all of these smooth muscle cells in one of these bronchial smooth muscle cell rings contract, then what's going to happen is all of them are going to decrease in length. And if all of these bronchial smooth muscle cells decrease in length, then the circumference of the entire ring of bronchial smooth muscle cells is also going to decrease. So, if the circumference of a circle goes down, then the diameter also goes down, because the diameter is the circumference divided by pi. So, here is my demonstration with my hands. So, here is a large circumference ring. Now, if the circumference decreases, okay, so I'm showing this by overlapping my fingers there, okay, what's also going to happen? Well, the diameter of the ring is going to necessarily decrease as well. So basically, when these bronchial smooth muscle cells contract, what's going to happen is you're going to get the constriction of these rings of smooth muscle cells. Now, when the rings of smooth muscle cells that are in this smooth muscle cell layer all constrict, then that's going to be transferred to the layers within, basically. So the lamina propria is going to get pushed in, the basement membrane will get pushed in, and the epithelial cell layer will get pushed in. Okay, so that results in the diameter of the lumen of the airway also going down. Okay, so contraction of these smooth muscle cells is going to result in bronchoconstriction. So bronchoconstriction is the fancy name for the constriction of a bronchus. Okay, so this leads to the narrowing of the airways, which is called bronchoconstriction. Right. Now, the smooth muscle cell layer is not part of the mucosa. The mucosa is the epithelium with the basement membrane with the lamina propria. So everything inwards of the smooth muscle cell layer is considered the mucosa, and everything outwards is going to be, well, actually not everything outwards, but the next layer that's just outside of the smooth muscle cell layer is going to be the submucosa. Okay, so it's the submucosal layer. So the mucosa and the submucosa are separated by this smooth muscle cell layer that's in between them. Okay, so this be the submucosa here. Right, so this next layer is what's known as the submucosa. Now, the submucosa is going to be full of what are known as submucosal glands. Okay, so what is a submucosal gland? Well, basically, submucosal glands are tubes that are running in the same axis as the bronchus, and they're running in this submucosa. Okay, so here is a submucosal gland, and basically it's a tube that is again lined by these columnar epithelial cells. Okay, so here are these columnar epithelial cells, and this is a submucosal gland, so I'll just label it up. So this is a submucosal gland. Okay, so these are little tubes that are running in the submucosa, okay, and they're lined by these epithelial cells which are not ciliated, and these epithelial cells are secreting mucus into the lumen of this submucosal gland, okay. Now, this all looks rather futile until I tell you that eventually this tube will come out of the submucosa and it will go through the smooth muscle cell layer, through the lamina propria, and it will be continuous with the epithelium of the bronchus, basically. So, these epithelial cells that line the submucosal gland, they are also sitting on a basement membrane, okay? And this basement membrane will be continuous with the basement membrane of the bronchial epithelium when the submucosal gland comes up to empty onto the surface. Okay, so if you want some intuition for this, imagine putting your finger into the airway here, okay, and then pushing your finger in to the epithelium. Okay, so that you produce a little invagination, a little tube, a little finger-shaped tube that's going to invaginate in through the lamina propria, through the smooth muscle cell layer, into this submucosa, and then you're going to sort of bring your finger round and then take it out in the same axis as the bronchus is moving, okay, and the tube will continue on propagating through that submucosal layer. Okay, and basically you have an invagination of the epithelial cells and also the basement membrane, and that's what these submucosal glands are. The difference is that the epithelial cells are no longer ciliated, okay, and they're producing mucus. So you secrete mucus into here, and then eventually the mucus will build up, move along the tube, out onto the bronchial epithelium, and then it will take part in the mucociliary escalator. So goblet cells aren't the only things creating mucus. These submucosal glands are also creating mucus. Right, surrounding the submucosa then, you have the final layer of the bronchus. Okay, so let's put this here, which is the cartilaginous layer. Now the cartilaginous layer is not a complete layer. So you don't have one continuous layer of cartilage all the way around the bronchus. Instead, you have these interconnected plates, as they're called, of hyaline cartilage. So let me colour these in bright green here. Okay, so in bright green, this is the hyaline cartilage, okay, of the cartilaginous layer. Right, so these are interconnected plates is how they're described. Right, okay, and really to understand how this works, how this produces a sort of meshwork around the bronchus, you need to look at this from a different angle. So this is a cross section. We're now going to look at a bronchus from side view, basically. Okay, so let me draw a bronchus here from side view. So no longer are we drawing a cross section, instead we're actually looking at it from the side. So here is our bronchus. Okay, it's a nice tube, and basically the cartilage will form a meshwork like so. Okay, so it might look something like this, so a sort of interesting meshwork like this. So at some points you will have a cartilaginous layer covering the submucosa, and then at other points you will have no cartilage, and the submucosa will be the outermost layer of the bronchus. Okay, so in green, this is the hyaline cartilage. Okay, so this is hyaline cartilage. And this sort of meshwork that you have here is what's known as an interconnected plate meshwork. Okay, so these are called interconnected plates of hyaline cartilage. Okay, right. So, hopefully you can see that if you cut through this, so if you were to cut through here, okay, and look at a cross-section as we did up here, you will see bits that have a covering of cartilage, such as this bit here, okay, and then bits where you don't have covering of cartilage, such as this bit down here, and this bit up here, and this bit works perfectly for what we actually have over here, okay? So this is why you see something like this. It's more of a structure than that. All of the plates are interconnected with one another, and it forms like this sort of meshwork around the bronchus that you can see will sort of hold the bronchus in nicely. Okay, right. So that's the structure of a bronchus. Now let's talk about asthma then. So what is asthma? Asthma is a chronic condition where you suffer from asthmatic attacks, okay? So, basically, if you have asthma, then from time to time you will get what is called an asthmatic attack. Now, what happens in an asthmatic attack? Well, basically, in an asthmatic attack, the smooth muscle cells of this bronchial smooth muscle cell layer contract, okay? And when they contract, that leads to the bronchoconstriction. It leads to the constriction of these rings of smooth muscle cells, and that narrows the airways. In addition, in an asthmatic attack, what you get is the swelling of the lamina propria. So you get inflammation within the lamina propria. This builds up an inflammatory exudate which makes the lamina propria swell, basically. And when the lamina propria swells, it'll push the basement membrane and the epithelium that's sitting on the basement membrane inwards. And that will also lead to the constriction of the lumen of the bronchus, okay? So these two factors are working against you. You've got contraction of the bronchial smooth muscle cell layer, which is going to constrict the whole thing. You've also got swelling of this lamina propria, which is also going to push inwards and reduce the lumen of this bronchus. So both of these things are going to lead to constriction or obstruction of the airways, and this could be happening in every single bronchus in your bronchial trees, okay? And therefore it's going to severely affect your breathing, okay? And these things can be fatal. If they obstruct your breathing enough, then they can cause asphyxiation, which we'll talk about later. Okay, right. In addition, asthmatic attacks, in the later phases of the asthmatic attack, what you get is damage to the epithelium. You get considerable damage and remodeling, okay? So firstly, you make the bronchial smooth muscle cell layer thicker. The more asthmatic attacks you have, the thicker the bronchial smooth muscle cell layer gets, and that means the more powerful it is, the more it can constrict the airways, okay? In addition, you get remodeling of the lamina propria to make it thicker, which means that even at resting state, before you've had an asthmatic attack, the bronchi are going to be obstructed, more obstructed than they should be, because if the lamina propria is just permanently thicker than it should be, then that's going to narrow the lumens of the airways. Okay, and also you get damage to the epithelial cells here, which can expose neurons from the lamina propria to the lumen, to the air within the lumen, okay? And this can trigger non-allergic asthmatic attacks. So let me just now talk about the difference between an allergic asthmatic attack and a non-allergic asthmatic attack. So asthma is commonly divided into two major types. Okay, so you have allergic asthma, which is reasonably well understood, and you have non-allergic asthma, which is basically just everything that isn't allergic asthma. Now, some non-allergic asthma is reasonably well understood, and some isn't well understood at all. And it's fair to say that in non-allergic asthma, you actually have a whole bunch of diseases that are probably caused by very different pathologies, okay? And it's basically anything that isn't allergic asthma is grouped together as non-allergic asthma. So what's the difference between allergic and non-allergic asthma? Well, the actual asthmatic attack is the same thing that happens. You get contraction of the bronchial smooth muscle cells and an inflammation of the lamina propria, and then in the later phases, remodeling of the lamina propria and the bronchial smooth muscle cell there, and also damage to the epithelial cells. Okay, but they differ in what actually triggers the asthmatic attack. So in allergic asthma, the thing which triggers the asthmatic attack is that you inhale an allergen, okay, which is a protein which you have launched a immune response against, okay. So the difference between an allergen and an antigen, okay, so an antigen is any protein that you are capable of producing an antibody against, whereas an allergen is a protein which you produce an antibody against, which doesn't deserve to have a humoral adaptive immune response initiated against it. Okay, so effectively these proteins are innocuous proteins. They don't deserve a humoral adaptive immune response being initiated against them. So if you've got an allergic response to something like pollen, you have initiated a humoral adaptive immune response against it. And non-allergic individuals will not initiate an adaptive immune response against it. Okay, so common allergens are things like pollen, okay, proteins associated with dogs and cats, so proteins that are shedded from dogs and cats. Proteins of the house dust mite, okay, is another common allergen. Okay, so all of these are proteins that really are innocuous. They shouldn't deserve to have a humoral adaptive immune response initiated against them because they're not going to cause any harm to you, okay, but you have initiated a humoral adaptive immune response against them even though they're not actually dangerous. Right, now non-allergic asthma, instead the asthmatic attacks are triggered by very different things. So for instance, if you inhale cold air, that can trigger an non-allergic asthmatic attack. You can also have non-allergic asthma attacks in response to environmental pollutants such as sulfur dioxide and nitrogen dioxide. The horrible chemicals in cigarette smoke can also propagate non-allergic asthmatic attacks. Okay. Viral infection can trigger non-allergic asthmatic attacks, but there are other things such as stress and anxiety that can also trigger non-allergic asthmatic attacks. Now, allergic asthma is well understood, and non-allergic asthma is not well understood. Okay, now, allergic asthma can eventually lead to non-allergic asthma, and the reason is that every time you have an allergic asthmatic attack, as I say, you damage the epithelial cells, okay, and this can gradually lead to the exposure of neurons which are within the lamina propria to the air that's within the lumen, okay. So if you imagine removing some of these epithelial cells, then it's plausible that neurons within this lamina propria will get exposed to the lumen and therefore be exposed to the air. And this is how you can then initiate allergic asthmatic you can initiate non-allergic asthmatic attacks in response to breathing in cold air, or environmental pollutants, or horrible chemicals in cigarette smoke. Because when you inhale them in, these stimuli can activate these neurons, and these neurons can then set off the asthmatic attack. However, things like how stress and anxiety trigger an asthmatic attack, those are not understood at all, really. And some people also have non-allergic asthma when they've never ever had allergic asthma. Okay, so it's not that simple. There's likely many different pathologies that can all lead to different forms of non-allergic asthma. What we're going to study is the well-understood one, allergic asthma, and then how it can propagate into non-allergic asthma to these non-allergen stimuli. Okay, but we're not going to look at things like how stress and anxiety can trigger an asthmatic attack, because very little is known about how they can. Okay, right, let's begin with an allergic asthmatic attack then. Okay, so allergic asthma then begins years and years ago when you first were exposed to this protein which you were going to launch an immune response to. So, years and years ago, maybe when you were a little toddler, you suffered the primary exposure to the allergen. Okay, so you get your first exposure ever to this allergen. So maybe it's pollen, okay? So your first spring, you breathe in pollen. Okay, and now what's going to happen is that you're going to initiate a type 1 hypersensitivity reaction to this allergen. Okay, so previously, before you've ever been exposed to the allergen, you have not had time to produce any antibodies against it. So if you haven't been exposed to it before, then you won't have activated a humoral adaptive immune response to it before. However, when you're first exposed to it, maybe in your first year of life, what will happen is you'll breathe it in, and then your body will initiate a humoral adaptive immune response to it. Now, this isn't just any old humoral adaptive immune response. The humoral adaptive immune response that you initiate against this allergen is going to result in you producing immunoglobulin E antibody against this allergen. Okay, so there are many different isotypes of immunoglobulin that you can produce, 9 in short. So let me just draw one here. Okay, so antibodies or immunoglobulins, those two words mean exactly the same thing. I'll just put that down, that immunoglobulin is the same thing as antibody. Immunoglobulin is the more fancy term for antibody. Okay, now antibody molecules consist of these 4 proteins stuck together. You have 2 heavy chains, which I'll highlight in pink here. Okay, so here in pink, here are the 2 heavy chains of our immunoglobulin. Okay, and those 2 heavy chains are linked together by disulfide bonds here. And now, you then also have 2 light chains, one here and one here, and each of the heavy chains gets a light chain bound to it by disulfide bonds. So here are the disulfide bonds which will link these light chains to these heavy chains. So let me just label them up. So in green, this is a light chain, okay, and in pink, this is a heavy chain. Right, so, firstly, now that we've done that, we can now separate the immunoglobulin molecule into 3 separate parts. Okay, so firstly, let me get the blue pen out. These portions up here, okay, so one there, and one over here as well. These are what are known as the variable regions, or also as the FAB regions, which stands for fragment antigen binding. Okay, so this is the portion which varies basically between all antibody molecules, okay? Well, it won't vary between all antibody molecules because you're going to produce loads of copies of this antibody, okay? So you're going to have loads of identical copies of this. But if you go to an antibody that's targeted against a totally different antigen, it will have a very different FAB region, okay? So this is the fragment, antigen binding. That's what the AB stands for. It stands for antigen binding. Okay, and basically this is the portion which is going to bind to your antigen. So different antibodies which are targeted against different antigens will have a very different FAB region. Okay, however, all of these IgE molecules that we're producing against this allergen, they will all have the same FAB region. Well, to keep it simple, we'll say they all will. Of course, this allergen will have multiple different sites that you could launch antibodies against to bind to, okay? So, let me just show this to explain. So if I draw an interesting shaped allergen here, so let's say this is the protein. Basically, you could make antibodies that are going to bind to this bit, antibodies that are going to bind to this bit, antibodies that are going to bind to this bit, and to bind to these different portions which are known as epitopes. So these different sites where you could bind to are called epitopes of the antigen. Okay, to bind to the different epitopes, you're going to have different FAB regions. So the reality is that you're going to produce a range of antibodies which can all bind to this allergen at different epitopes. And the different antibodies that will bind to different epitopes, those will have different FAB regions. But for each one which binds to a specific epitope, you'll produce many copies of that immunoglobulin molecule, and those immunoglobulins will all have an identical FAB region. Whew, that's a lot to explain. Right, okay, so the other region then is in orange down here. Okay, and this is what's known as the fixed region or the constant region or the FC region. Okay, and FC stands for fragment crystallizable. Okay, now there are different types of immunoglobulin molecule that you can make. Okay, there are 9 different types, and these different types will vary in which FC region you have. So we've discussed that this FAB region will vary between all different antibodies which target different antigens, and also different antibodies which target the same antigen but different epitopes of that antigen. They will all have different FAB regions. Okay, so you firstly have to decide what FAB region you want. We have chosen a specific epitope of this allergen, and we've now fixed this FAB region so that it binds to that epitope. But then you also have another choice, which is which FC region you want to use, which fragment crystallizable you want to use. Now, there are 9 different types. Okay, so there is what's known as IgA, and there are 2 different types of IgA. There's IgA1 and there's IgA2. Then there is IgM, and there's only 1 different type of IgM. Okay, there is then IgG, and there's 4 different types of IgG, 1, 2, 3, and 4, known as IgG1, IgG2, IgG3, IgG4. Then there's IgD, there's only 1 different type of IgD, and then finally there's IgE. And I've saved the star of the show till last. We are going to specifically always use IgE. Okay, so you're specifically going to produce a huge number of immunoglobulin molecules which have an FAB region which can bind to an allergen, can bind to an epitope of this allergen, and they're all going to pick this FC region to be the IgE FC region. Okay, so you're going to produce a lot of immunoglobulin E, and Ig is short for immunoglobulin, E, immunoglobulins against the allergen, okay? And these are going to go into your blood. So this is all happening upon primary exposure. You're producing a lot of these immunoglobulin E molecules against an epitope of this allergen. Now, what's now going to happen is these IgE molecules are going to get mounted on receptors on the surface of the mast cells. Okay, so they're going into the blood, and they're now going to disseminate around the body. They'll go into all the tissues of your body, well, not all of them, but a lot of them, and they'll get into the lamina propria, basically. They'll go into the blood vessels within the lamina propria, and they'll move out of those blood vessels into the lamina propria itself. And there, they will come into contact with these mast cells. Okay, so let me draw a mast cell here. So, mast cell, here is the nucleus of a mast cell, okay? And then within a mast cell, what you have is a bunch of mast cell granules which contain histamine, basically, but we'll discuss those in a moment. First, let's just discuss that on the surface of mast cells, you have a receptor known as the Fc epsilon R1 receptor. Okay, so this is the Fc epsilon R1 receptor, and it's a protein, an integral membrane protein complex that sits on this membrane and is involved in binding to the IgE molecules. Okay, so why is it called this? Well, Fc means fragment crystallizable. The epsilon refers to the fact that it's going to bind to the fragment crystallizable of IgE molecules. So remember, these Fc regions vary within the 9 different types of immunoglobulin Fc region. Okay, so this is specifically only going to bind to the Fc region of IgE molecules. And then the R is for receptor, okay, and then the 1 is just for 1, type 1. Okay, right. So what's going to happen is these IgE molecules that you've produced against this allergen are going to be mounted on the surface of these mast cells on Fc epsilon R1 receptors. Okay, so here is the IgE molecule now on the surface of this Fc epsilon R1 receptor. Now, let's just discuss the purpose of mast cells for a moment. What is the purpose of mast cells? Well, basically, mast cells are a cell that sit everywhere in your body. You have them interdispersed among all the tissues of your body, and their job is basically as a sentinel cell. They sit and watch and look out for pathogens all the time, so they're always on the lookout looking for pathogens, for signs of pathogens. And if they see pathogens, they're going to start producing and releasing a huge number of alarm signals, basically, and these alarm signals are then going to trigger an acute inflammatory response, the aim of which is going to be to try and stop the pathogen, basically, try and kill the pathogen. Okay, so what we have now done is we have stuck this IgE molecule on the surface of a receptor on the surface of the mast cell. Okay, now when the allergen, if you ever get re-exposed to the allergen, if the allergen comes into the lamina propria and binds to this IgE molecule, which is targeted against it, that will then activate the Fc epsilon R1 receptor and trigger the mast cell activation. Okay, so now what we have effectively done is we've armed these mast cells so that they are on the lookout for our allergen. That's what this is doing. This is a complex for looking out for this allergen. Okay, so the body thinks that this allergen is extremely dangerous. So what it's basically doing is it's handing these IgE molecules out to its sentinel cells, to its mast cells, to its lookouts, and saying, use these. If anything it comes along and binds to these, we know that that allergen is back again, and we need to initiate a response to it. This time we'll be ready because you will see it early on. Okay, so this is the body trying to protect itself, but the reality is it's initiating all of this against something that really is not worth it. Okay, and I just want to discuss a little bit of terminology with you as well. So, IgE, when you produce a humoral adaptive immune response that produces IgE against an allergen like this, i.e. an antigen that is not worthy of having all of this done in its aid, okay, this is known as a type 1 hypersensitivity reaction. So, when you initiate a humoral adaptive immune response against an unworthy antigen, such as an allergen, that results in the production of IgE targeted against that allergen, then it's called a type 1 hypersensitivity reaction. Okay, and it's going to result in the production of this IgE, which is then going to mount itself on the surface of the Fc epsilon R1. Now, after a few weeks, of the primary exposure, what will happen is the humoral adaptive immune response will calm down. You'll stop producing more IgE. The IgE levels in the blood will go down, but the IgE that's bound to Fc epsilon R1 receptors will remain there for months and months and months. And if you get another exposure of the allergen, if you get exposed to the allergen again, whilst the IgE is still on the surface of the mast cells, then the mast cells are going to release a huge number of alarm signals, and that's going to trigger the asthmatic attack. Okay, now we'll continue this discussion in the next video.